Okay, guys, chapter 39, and this is kind of the big one, I think. I don't know. I don't know which one was bigger, I guess. Anyways, fluid, electrolytes, and acid-base balance. Here are your learning outcomes for the chapter. So normal structure and function. So there was some things I did want to hit on for sure. So, and you covered a lot of this in your study guides, which I'll finish grading today. But anyways, so body fluids are either intracellular or extracellular, and the extracellular component has the interstitial fluid, so all the fluid between the cells. The intravascular fluid is the fluid in our blood, so or in our veins and our arteries. So that's the plasma, of course, but intravascular means in our veins or in our arteries. And then the transcellular, which there's a few places for it. So that's your spinal fluid, your in your pleura and pericardial membranes, that fluid, the fluid of your eye, digestive juices. Otherwise, fluid is in the body is either intracellular or extracellular, and the extracellular comprises the interstitial fluid, so around the cells and within the organs or tissues. And then intravascular is your plasma or the fluid that is in your veins and arteries. And then transcellular, okay? So the fluids are composed of water and solutes. Okay, solutes are substances, of course, that dissolve in the liquid, and of solutes, crystalloids dissolve easily, and colloids do not dissolve easily. So your solutes contain your electrolytes. There's some proteins which do not dissolve easily. There's oxygen, carbon dioxide, and glucose. Okay, so those are all the kind of things that comprise solutes. All right. So water moves in and out of the cell from the interstitial to the intervascular spaces, and the movement from those places happens by either osmosis or filtration, and then there's some little caveats to each one of those. All right. Now, the cell membrane allows water to move across readily, but solutes do not. So they have to be. There's some certain criteria in which solutes move across. Now, water moves by the process of osmosis from an area of lower concentration of solutes to an area of higher. So, oh, I don't have that picture yet. I have a picture on another slide. But so water moves, just the water moves by the process of osmosis, and it moves when there's a lower concentration of solutes. It moves to the concentration of higher solutes, okay? And the purpose is to equalize the distribution of the solutes in and outside, or the cell and outside the cell, okay? And then the side that has the higher concentrate of solutes is the side that has the greater osmotic pressure to pull that water across. Okay, so then there's equal solutes dispersed in that water on each side. So as we said, osmosis is the movement of water across the cell membrane, and the side of that membrane that has the most solutes has the most osmotic pressure. So, again, water moves from lower osmotic pressure or lower solutes to a higher osmotic pressure or higher area of solutes. Okay, so this diagram kind of shows, and it gives you the correct terminology to use. So the water in this space moves because this is a few solutes. This has a lot of solutes, so there's there's higher pressure, osmotic pressure on this side. So the water moves from outside to inside and then makes it all equal. Okay, so this would be hypotonic. Okay, hypertonic is there's more solutes outside this cell, and so the water from inside the cell moves outside of the cell to equalize it. All right, and then isotonic is same on both sides, and the water can just move freely in and out, but the same amount of solutes, so the pressure is the same on either side. Isotonic. Okay. All right. Some of the fluids that we administer, and we're not going to talk a lot about IVs and IV fluids in this course. It is saved for your pharm course, but just to hit on it a little bit. So when we give fluids to a patient, we give it through their IV, of course, and so that's intravascular, and then that fluid is able to, it contains different amounts of solutes, and so depending on our goals for our patient for whatever type of fluid or electrolyte imbalance they have, will determine what kind of fluid we give them. And even if they don't have some sort of fluid or electrolyte balance, depending on the fluid that we give them, we might create one. So any fluid that has the same osmolarity as as the plasma in the blood is considered to be isotonic, and normal saline is one of those solutions. However, normal saline is 0.9% sodium chloride, so even though it's isotonic, if we give that over a long period of time, then we will be giving a patient too much sodium. So it's not a drug that we give, it's not a fluid that we give as a maintenance fluid to be running all the time. We use it in certain circumstances for a short period of time. Lactated ringers, however, is the one that most closely resembles blood plasma, and it contains all these solutes: sodium, potassium, calcium chloride, and lactate. And we can use this one as a maintenance fluid. Now, a fluid with higher osmolarity or a higher concentration of solutes would be considered a hypertonic solution. Examples of those are the D5LR, D5 half normal saline, we call this half normal saline even though it's 0.45, or D5 normal saline. So they will pull water from the cell to the extracellular fluid compartment. So remember, we're putting this hypertonic solution in their vasculature. So there's a higher osmotic pressure in the vasculature, and what happens? Remember back the few slides before, what happens is that causes water to be pulled into that area. Okay, so it's being pulled out of the cell into that area. So that's causing like shrinkage of the cell. So we're taking water out of the cell, okay, because of this higher concentration of solutes that we're putting into the patient. Now, oppositely, fluids with a lower osmolarity, so they have a lower concentration of solutes, they're considered hypotonic. So that's your half normal saline or less, quarter normal saline, and then excess water. So we'll have more solutes in the cell than we are putting in the body. So the water is going to move from the lower concentration, which is intravascularly, to the cell. All right, and so more water will go into the cell, leading to cell swelling. Okay, so sometimes this can be kind of difficult to understand, especially when you start adding filtration to the mix or active transport. But just let me know. Let's talk through this if you have any questions, okay? Now, in the intravascular space, to maintain osmotic pressure there, we have plasma proteins, mainly albumin, that holds the pressure stable in the vasculature, and it holds water in the plasma or in the vasculature. Okay, so the presence of these proteins creates what is called a colloid osmotic pressure or an oncotic pressure. Okay, so you just have to learn that. Nothing fancy about that, but when there's proteins in the vasculature, to maintain the pressure there and maintain the water balance there, it's termed colloid osmotic pressure or oncotic pressure. Now, these plasma proteins, they're larger, so they do not pass through the membranes. They stay in the vascular space. Now, they can come out of the vascular space, and usually that is a result of some sort of trauma to the vessel. Now, just think of the patient with a severe decubitus ulcer, or a tunneling ulcer, or a fourth stage ulcer. Okay, that's a case where a patient can lose these plasma proteins. The plasma is seeping out these broken vascular vessels, and just seeping out of their body. And these patients a lot of times will end up getting albumin drips to replace that, so that they can keep their plasma volume. All right. Now, filtration, on the other hand, is when fluid or water and solutes move together. Now, they go from an area of higher pressure to an area of lower pressure, so that it's kind of opposite of the osmosis, and it takes both fluid and solutes. Okay, they go together from an area of higher concentration or higher pressure to an area of lower concentration or lower pressure, and that pressure is called a hydrostatic pressure. All right, and especially in the vessels, that pressure is controlled by the force of heart contraction, or the heart rate, the force of the heart pumping the blood through. Okay. All right. So as we said, filtration is from the higher pressure to the lower pressure, and this is how oxygen and carbon dioxide are exchanged, actually, is this filtration process. Okay. Now, in order to, another way that we control our fluid balance is a few other mechanisms. The renin-angiotensin system, by the use of antidiuretic hormone, and by use of the first mechanism. So the renin-angiotensin system regulates blood pressure and fluid balance by constricting, vasoconstricting, and by excreting or reabsorbing sodium. So we'll see that process. We'll break that process down. Also, antidiuretic hormone is responsible for controlling the amount of water excreted in the urine, and then because of many factors that stimulate the thirst center, so those receptors that detect all these different levels of water balance, blood pressure, and solute pressures, it will trigger our thirst. It will trigger those receptors, which activates our thirst mechanism. Okay, so we'll kind of break these down. Now, so when we talk about a decrease of fluid volume, so this is in the vasculature, A decrease of fluid volume is called hypovolemia. And when we have this scenario happening, we have a decrease in blood pressure. Now, that decrease in blood pressure stimulates the release of renin, an enzyme called renin, and then that renin converts angiotensin to angiotensin 1. And then another enzyme, angiotensin converting enzyme, then changes angiotensin 1 to angiotensin 2. And then that hormone is what is responsible for all the changes. So angiotensin 2 causes vasoconstriction, which increases our blood pressure. It causes the reabsorption of water that takes place in the kidney into the intravascular spaces. It stimulates the adrenal cortex to release the hormone aldosterone, and then aldosterone works on the kidneys to increase the amount of water and sodium that is reabsorbed back into the blood system. Okay, and then it also stimulates that thirst mechanism, that receptor that detected the low blood volume, and it causes us to thirst. Now, all these things act together to increase our blood pressure. So back here when we had the hypovolemia, we had the decreased blood pressure. It activated all these mechanisms that went and helped us to restore our blood volume or our plasma volume, and then therefore increase our blood pressure. Now this is, if you like diagrams, this is that renin angiotensin mechanism, and you can see where all these things are taking place that was in that list. So whichever you prefer to use to study is fine. Now, when the osmolarity of blood pressure increases, that means, so that's another sign of hypovolemia. So we have, we may not have low fluid, but we have a lot higher concentration of solutes. But we do see that with dehydration, and then we can see that when our fluid volumes are normal, but our solutes have a higher concentration. So anyways, they stimulate the secretion of the antidiuretic hormone. And break that word down. So antidiuretic. So we don't want to diurese. Diurese is when we get rid of fluid. We don't want to get fluid. We want to save the fluid. So so we don't want to diurese. So we need that antidiuretic hormone. And so that also works on the kidneys to reabsorb more water, and of course less urine is produced. And then as the water moves back into the bloodstream or back into the plasma, the osmolarity normalizes, and then that's the feedback loop to stop releasing the antidiuretic hormone. Okay. And then so here is another diagram of how all these things happen, and it also stimulates, again, the thirst center to cause us to drink. Okay, so here's that diagram for your study. Now, aldosterone, when the plasma volume is low, it stimulates the kidneys to retain or reabsorb water and sodium, okay, at the same time. So that doesn't affect the osmolarity, okay. We reabsorb water and sodium, which increases our volume, but it doesn't affect the pressures from the solutes, okay. Antidiuretic hormone, it does the opposite. It stimulates the kidney to reabsorb water only. So what we're going to see is more water for the solutes that we have, so they become dilute, which means we decrease our plasma osmolarity. All right, atrial natriuretic peptide is secreted in the heart, stimulation in response to an increase in blood pressure. And ANP causes the kidney to increase the glomerular filtration rate, which leads to excretion of water in the urine. So when our blood volume is higher, our blood pressure is higher, ANP will cause the kidney to excrete more urine. It also will block that renin-angiotensin system that is activated when our blood volume is low and our blood pressure is low, so it stops that from being secreted. Now, when we talk about electrolytes or our solutes moving in and out of the cell, they have to move either by diffusion or filtration and active transport. And we talked about filtration. Filtration is the process of water and solutes moving across the cell from an area of higher concentration to lower concentration. Okay. Diffusion is movements of solutes across the membrane from areas of higher concentration to areas of lower concentration. And then facilitated diffusion is when the solutes need a carrier to cross the cell membrane. And an example of that is glucose and insulin. So when glucose is moved into the cell, it needs the help of insulin to do that. Active transport is when you go from an area of lower concentration to higher concentration. So before we move from the higher concentration to the lower concentration to equalize things, here this active transport is going the opposite way. So an example of that is the sodium-potassium pump. It's an active transport process because it requires energy to move across from a lower to a higher concentration. Now, on page 994 is the table of all the electrolytes, and I need you to know those, and there's a bunch of them. And the ones in particular that you have got to know beyond a shadow of doubt is sodium, potassium, calcium, and magnesium. Chloride and phosphate, I want you to know those as well, but especially sodium, and especially the top four, sodium, potassium, calcium, and magnesium. Those are the ones you're going to be hearing about the most and talking about the most, not only in this class, but in your future classes and future semesters. So these are your electrolytes. These are the normal values, and you've got to know these, okay? You're going to see these in future classes. And the reason why I point that out so emphatically is because some of your classes, your future classes, your teachers come to me and say the students don't even know these. They say they've never seen these before. And it's because probably you learned them from my class and then forgot all about them. Or maybe you crammed and didn't learn them, just memorized them. You've got to learn these. You've got to know these, okay? Because you're going to be seeing when we do labs on patients, electrolytes, you're going to be seeing these values, and you're going to need to know what the normals are. Of course, when you get a lab value, the lab will print the normal values as well, but you need to know these, okay? I can't stress this enough. All right. Now, we also need to talk about acid-base balance. Acid-base balance is very important for our body to function normally. And here are the normal values of acid-base balance. Now this is, you will see these on your arterial blood gases. So a normal pH, you have got to know these values. And I'm going to keep stressing, you've got to know these. So normal pH in the human body, 7.35 to 7.45, you've got to know this. The normal CO2 is 35 to 45. You've got to know this. The normal bicarb, or HCO3, is 22 to 26. You guys got to know this. The normal oxygen content is 80 to 100. And remember when I said, and then your normal O2 is 95 to 100. So you remember when I said O2 sat and PaO2 are different. This is the oxygen content in the blood. PaO2 is oxygen content in the blood. 80 to 100 is normal. And then the O2 sat is the amount of oxygen, hemoglobin saturated with oxygen. Okay? All right, so you got to know these values. Now, if those values are off, if there's some sort of acid-base imbalance, the body does have some mechanism in which to try to normalize those values. So there's a buffering system, a chemical buffering system, there's a respiratory control, and there's a renal control. And we'll go through those, okay? Here is your buffering system. So if you are either too acidotic or too alkalotic, this can work in reverse both ways. So it can buffer an acidotic system, or it can it can alkalize an acidotic system, or it can acidize alkalotic system. So it can go both ways. Okay, I don't need you to memorize this formula. It's just important to know that this buffering system within the body, this is a chemical reaction that can help normalize acid-base imbalances in the body. Okay, and here's another example of a phosphate buffering system, and how it can normalize acid-base imbalances. I don't need you to know this chemical reaction. Just be aware. Okay? So we're going to more focus on the respiratory and the renal components of this of a buffering system. So as we breathe in oxygen, we exhale carbon dioxide. And carbon dioxide is acidotic. So if we have too much, if we have a higher acid-base balance in our system, then our respiratory system will try to compensate by blowing off CO2. So carbon dioxide is acidotic, and if our system is acidotic, then the respiratory system will try to blow off more CO2, or blow off that acid to try to normalize our acid-base imbalance. Okay. Now, also in relation to that, if we're too alkalotic, the respiratory system will try to conserve CO2 to try to normalize our alkalotic state. So if we're blowing off CO2, we will try to normalize an acidotic state, and if we're retaining CO2, then we're trying to correct an alkalotic state. Okay. That helps our compensation. And that's a quick fix, but it also cannot last forever. So we have to find out what is causing us to be acidotic or alkalotic. So we can't keep, breathing fast to blow off CO2 for the rest of our life, or we can't keep breathing slower to retain CO2 the rest of our life. We have to find out what the problem is. So the respiratory assistance is a quick fix, but it cannot be maintained for a long period of time. Now, so the renal regulation or the renal help is so the kidneys can excrete or retain hydrogen ions or form bicarbonate ions. So hydrogen ions are the acidotic component, and then bicarbonate is the neutralizing or the alkalotic component. Okay, so if the kidneys detect an acidotic state, well, then they'll start excreting more hydrogen ions and creating or forming more bicarbonate ions to neutralize that. If the kidneys detect an alkalotic state, then they will start conserving hydrogen ions or the acid, and then they'll start excreting or stop forming so much bicarbonate ions. Okay, so just kind of walk that through. All right. Now, the renal mechanism or compensation takes a longer period of time, but it can be sustained a little bit longer than the respiratory. So it takes several days for this to occur. So the renal compensation needs to be subsidized until it kicks in. Okay. Now, when we talk about fluids and electrolytes, we also need to talk about our blood groups. So this is probably a review for you guys. So this is typing whether or not we're A, B, or O blood types, and whether or not we are Rh positive or Rh negative. Now, we determine that by for the ABO typing, we determine that by the presence of the antigens on the red blood cells. So if there's A antigens, then you're type A. If there's B antigens, you're type B. If there's both, then you're AB blood type, and if there's neither, then you're O blood type. And then Rh, if you're Rh positive, that means you have the Rh factor on your red blood cells. If you're Rh negative, you do not. And so when it comes to blood transfusions, we need to, we need to match the patient with the donor blood to make sure that, one, they're the same, and then they mix those, and then make sure that there's no reaction in the lab, and then they're able to give that blood to the patient. So here we are again. So the A antigen is type A, and so forth and so on. Now, for a patient who is AB type blood, then they are considered to be the universal recipients, meaning that they can get any type of blood. They can get A blood, they can get B blood, they can get AB blood, and they can get O blood. Now, a person who is type O, remember, type O has no antigens on their blood cells. So type O people are universal donors. So they can give blood to any of the different blood types. Okay, but they can't get blood from any of the different blood types, because why? Because they don't have antigens on their blood. So if they receive blood of another blood type, they're going to detect those antigens on those blood cells, and they're going to see those as foreign, and they're going to lyse those blood cells. So if a patient is type O, they can give their blood to anybody, but they cannot receive blood from anybody. Okay, so do you guys I hate recording because I don't know if you have questions. Anyway, so let me know if you guys need a little better handle on that. And then we talked about RH. So RH, positive people have the RH antigen. If they're RH negative, they do not have that antigen. So again, just like with the type O, we cannot give an RH negative person who does not have the antigen, we cannot give them RH positive blood because they will see that antigen and create an antibody. However, an RH positive person could receive RH negative blood because they will not, there's no antigen on it, they will not create antibodies. And we will be discussing this, especially RH positive and RH negative, next semester when we talk about pregnant women, but it is an important component to managing a pregnancy of a woman who is RH negative, because we don't know if her fetus is RH positive, and if her fetus is RH positive, and there is any type of crossing of the blood from mom to babe, or from babe to mom, then mom's body will create antibodies and attack the fetal red blood cells. So we'll talk about that more. If you want to talk about it, I mean, we'll talk about that more next semester. But if you want to talk about it more now, just let me know, and we'll discuss it. All right, so on page 34, on page 996, there is a table that has all the different blood components, and I do want you guys to review that and know those different blood components and when we give these type of blood products to patients, okay? All right, altered structure. So fluid imbalances. So excessive fluid loss is a hypovolemia of some sort. So that means we have decreased circulating blood volume, which will affect blood pressure. It'll affect cardiac output, and then eventually and then heart rate. So if we have a decreased fluid volume, we'll have a lower blood pressure. Of course, we'll have a lower cardiac output because we don't have the volume, and then our body will compensate by increasing our heart rate to start pumping more blood out. Now, if we have a fluid volume excess or hypervolemia, then we will be seeing an increase in cardiac output. We'll see an increase in blood pressure, which actually increases the workload on the heart. And I do want you to review also the table on page 997 of the fluid excesses, the different kinds of fluid excess and the different kinds of fluid loss, okay, and how we treat those. Now, one thing that we look for when we see fluid volume excess is edema, and we will see it all throughout the body. So they can have a generalized edema all throughout the body. They can have edema to their face, their hands or fingers, their ankles and feet. They could have edema going up their legs into their thighs and hips. We could have edema in the abdominal region, and then also we can have edema in the lungs, and we hear that when we auscultate our lungs, our breath sounds. You may hear people call it third spacing. So instead of fluid being in the cell where it belongs, or in intravascular where it belongs, or in the interstitial where it belongs, it's dumping in the extra spaces, and they call that third spacing. Okay. So for causes of edema, we have an increase in hydrostatic pressure due to a fluid volume overload. We have a decreased production of the circulating plasma proteins, or we're losing plasma proteins for some reason. Remember I said the plasma proteins like albumin is what circulates in our plasma, and it holds the water in our plasma. So if we don't have those, then we're going to be leaking fluid. We can have an obstruction of lymphatic drainage, and then increased capillary permeability. So basically vessel damage, where the fluid leaks out into the interstitial spaces and is trapped there because it can't be absorbed or get back in. So we have tissue damage or vessel damage. Okay. Now, there is a thing having a simultaneous fluid volume excess and deficit. Now, this is when that albumin, so remember, albumin is the protein that circulates in our intravascular space. So when our albumin is low, we cannot maintain our fluid volume in our vasculature, and fluid seeps out into the interstitial spaces. Okay, so we will see a low volume fluid volume deficit there, and we can see edema. We can see weight gain. We can have that fluid into our pulmonary system, so we'll hear pulmonary congestion. Now, because of not having the fluid in our intravascular space or in our vessels, then we will see that fluid volume deficit, where we see hypotension, we see weak pulses, we don't have the vascular volume, so we have poor cardiac output, we have low blood pressure, and then so we increase our heart rate, so we'll see tachycardia. So, you would think, well, let's get more volume on board, let's give them an IV, but the problem is we don't have the albumin or the plasma proteins holding that fluid that we're giving in our vasculature. So what we need to do is we need to replace those plasma proteins, all right? And that will start holding our fluids in our vascular, intravascular spaces, okay? And then we can start, giving more fluid, either orally or intravenously, once we get those plasma proteins back in our system. And then we have to get rid of the fluid volume excess that we're seeing in the form of edema. Okay. All right. So electrolyte imbalances. So on page 999, that's a huge section. Again, I want you concentrating on potassium, sodium, calcium, and magnesium. It talks about the signs and symptoms that you'll see and things like that for the different electrolyte imbalances, whether you have too much potassium or not enough potassium, and so forth and so on with the other electrolytes. So this is a huge chapter. This has got a lot of stuff you need to study and memorize and learn, okay? Because you need to carry this information on throughout your nursing courses and other semesters, okay? All right, and then on page 103 to 1003 to 1004 is your acid-base imbalances. So this is going to be talking about your respiratory acidosis and your respiratory alkalosis. It's going to talk about your metabolic acidosis and your metabolic alkalosis. So you need to look at those as well, okay? What your lab values will look like, and what signs and symptoms and things like that you'll see in your patient. So this you will also need to just memorize. This is so you need to work in groups, you need to quiz each other, you need to make flashcards, whatever you guys do, you need to learn all these different normals, and all the different abnormals, okay? All right, so respiratory acidosis, so we have, we're retaining too much CO2, all right? So that when we have too much CO2 in our system, that's called hypercapnia. That is, carbon dioxide is a acid, and so it causes our acid levels to rise, so that is a respiratory acidosis, okay? Of course, it can be acute or chronic. And then, so when we see respiratory acidosis, we see our pH number going down. So the lower the pH, the more acidotic you are, okay? And then, of course, we're retaining carbon dioxide, so we'll be seeing our carbon dioxide increasing. So it's an inverse relationship. So when you have respiratory acidosis, you have a low pH and a high CO2, okay? Now, in chronic respiratory imbalances, like in COPD, so this is a chronic disorder, you have high CO2 levels. Remember, like the retain, so it's like that emphysema where they have that gas trapping in their alveoli. They're not blowing off the CO2, so they have a high CO2, and so you would think that their pH would be low or they would be acidotic. Well, their body has compensated, and so we will see a normal pH. Okay, so they will have a normal pH, but they'll have a high CO2. So that's a compensated respiratory acidosis. It's respiratory because it's the carbon dioxide, but the pH is normal, so it's been compensated. Oh, here we're talking about, so compensation. And remember, it's the renal compensation that happens. So the kidneys are excreting hydrogen ions to try to normalize the acidosis, and they are conserving or forming bicarbonate. Okay, so that's our compensation. All right, respiratory alkalosis. So we are blowing off too much CO2, so we're alkalotic, and so we do that when we hyperventilate. Okay, and so when we look at our blood gases, our pH, so if we're alkalotic, our pH is higher. Okay, so greater than 7.45, so it's greater than 7.5, that means we're alkalotic, and then our PO will be decreased, or I'm sorry, PCO2 will be decreased, so it'll be less than 35, which is less than normal. Now, I put this less than sign in red because I wanted you to look at the student PowerPoint slides that have been posted. I think that was in there incorrectly. I think it said greater than 35, and that's wrong. It needs to be less than 35. So I just wanted to point that out and see if you guys could check that and correct it on your, if you printed those out or if you have them saved or whatever. Okay. So so we're hyperventilating, and the renal compensation for that is now the kidneys are going to start conserving hydrogen ions and excreting or not forming the bicarbonate ions to increase our acid levels. So that's a renal compensation for respiratory alkalosis. So what we would call that, so what we would see is we would see our pH to be normal. Our PCO2 is still going to be low, right? Because that's telling us it's the respiratory component. So our PCO2 is still going to be low, all right, but our pH is now going to be normal. So we know that our kidneys have compensated. So that's called a compensated respiratory alkalosis. All right, this is all very confusing, but if you just slow down and talk through this and think about the process. So if we need to discuss this more face-to-face, We certainly can. This is why I hate recording. But anyways, so moving on. So a metabolic acidosis. So this is a kidney process. So we're losing too much bicarbonate. Remember, bicarbonate is our alkalizing agent. We're losing too much bicarbonate, and or we're producing too much acid, which is our hydrogen ions. All right? And so that will give us a metabolic acidosis, where we're going to see our pH is less than, our pH is low or less than 7.35. That tells us we're acidotic. And then we're going to see that our bicarbonate level is also low as well, because we're excreting or losing or not forming our bicarbonate ions, okay? So our bicarbonate level is our HCO3 is going to be low, all right? And so to compensate for that, for acidosis, our lungs, so here's some reasons, I'm jumping ahead. So here's some reasons why you might be losing or be in metabolic acidosis, okay? So diarrhea, malabsorption syndrome, okay? Anyways, so here's our compensation for metabolic acidosis. So the respiratory system tries to kick in and help out, and so what it will do is, since we're acidotic, it's going to try to blow off CO2, because CO2 is an acid, right? So we're going to increase our rate and depth of respirations and trying to blow off CO2. So if we have compensated metabolic acidosis, we are going to see our pH, when it's compensated, that means our pH is now normal, okay? And but we're also going to still see that our bicarbonate level is low, because we didn't really correct the problem. We're just trying to help out the acidosis part, okay? So we still have metabolic acidosis, but now it's compensated because our pH is normal, all right? Now, metabolic alkalosis. So for some reason, we are retaining bicarbonate. And one way is because we are taking too much medications that have bicarb in them. We're vomiting. We have too much suctioning that's taking our bicarbonate ions. But for whatever reason, we don't have enough, too much bicarbonate. I'm sorry, I said that wrong. Anyways, so that's a metabolic alkalosis. So we're going to see our pH to be high. So when our pH is high or above 7.45, we're alkalotic. And then we're going to see that it is a metabolic process because our bicarbonate levels are too high. We can see that here are some reasons why we would have that. So some medications will cause that. Well, medications will give us too much bicarb, or medications will cause us to lose too much hydrogen ions, which is an acid, which will end up making us alkalotic, okay? So different medications will do each one of those things, okay? Depending on the medication. Now, to compensate for metabolic alkalosis, the lungs will kick in, and they will try to conserve acid or conserve CO2 or carbon dioxide, and so we will start breathing less and more shallow, okay? So we'll try to be keeping that carbon dioxide to compensate for our alkalosis. So we're trying to make our body more acidic. And so when that happens, we will see a normal pH because we've compensated, but we still have those abnormal bicarbonate levels, those elevated bicarbonate levels, until we correct the actual problem. All right? Okay. So here are your health assessment questions for fluid and electrolyte imbalances, if you need to question your patient more. So the first thing that we're going to do for our assessments, of course, First thing usually with anything is check vital signs. Now there's some things that can kind of clue us in on what's going on with our patient. For instance, if we have a prolonged fever, we know that we're probably losing a lot of body fluid from our fever, and we can be in a dehydrated state, and then we could see rising temperatures as well with that. Our respiratory rate, so depending on what kind of acid-base balance we have, we might see our respiratory we might see a respiratory problem if it's a respiratory acidosis or alkalosis. But if we're compensating for a metabolic problem, then we'll either see a fast rate or a slow rate. Okay, tachycardia or increased heart rate, so that's related to a fluid volume deficit. So we don't have as much circulating blood volume, so we have a decreased cardiac output, we have a decreased blood pressure. So to compensate for that, our heart is going to increase its rate to try to get more fluid pumping. Okay, and then also if we have problems with our heart rate, if we auscultate an irregular heart rate, we might have an arrhythmia, and so, or a dysrhythmia, same, and that might tell us that we have some electrolyte imbalances if our heart is not pumping or is not beating correctly. Okay, and then when we palpate our pulses, if we have weak thready pulses, then we know we have a fluid volume deficit, and if we have overly strong or bounding pulses, we might feel like we have a fluid volume excess. Blood pressure changes, again, if we have a fluid volume deficit, we're going to see lower blood pressures. If we have a fluid volume overload or excess, we will see higher blood pressures. Okay. And then this is where you might want to do your orthostatic blood pressures, is if your patient has a fluid volume deficit, and you do these orthostatic blood pressures, you can see a decrease with each position change in their blood pressure. Pulse pressure, so this is a mathematical calculation. It's systolic subtracted, or the diastolic subtracted from the systolic. So if your pulse pressure is less than 24, then well, really, if it starts going less than 40, depending on the person's normal blood pressure, you might be seeing a fluid volume deficit. But especially if it's less than 24, that is a severe fluid volume deficit. Electrolyte imbalances can also affect blood pressure. So there might be no problem with your blood volume, but if you have too much sodium, too little sodium, things like that, then it can change. It can affect your blood pressure. Okay. So we also want to, after we've assessed our vital signs, we want to assess our intake and our output. And so our intake is anything that goes into our body. Even foods convert, once they're digested, do convert to a fluid volume. But when we're doing INOs and charting those and documenting those, it's going to be on fluids. So any food that's a fluid at room temperature is going to be included in this calculation. And then, of course, any IV fluids that we put into the patient, any irrigations, anything like that is going to be part of our intake. So all the water they drink, all the popsicles they eat, all the IV fluids we put in, all of the bladder irrigations that we do, all that fluid in the body is going to go to our calculation. And then all the fluid that comes out of the body is going to go for our output. So vomit, diarrhea, of course urine output, and then if you have irrigated a body part, a body cavity, the fluid that you put in goes into your intake total, but the fluid that drains out goes into your output total. And then we do a 24-hour total. So some of your intake and outputs, I'm sorry, I'm jumping around here. Some of your intakes and outputs will be calculated on an hourly basis, some every 4 hours, some every 8 hours, but then you're always going to be doing a 24-hour total. And then we want the 24-hour total to either be equal or a positive balance. So a positive balance, well, in some patients, I'm sorry, I shouldn't have said that. A positive balance is when the intake is more than the output, okay? A negative balance is when the output is more than the intake. Now, the reason why I corrected myself is because if a patient has some sort of cardiac defect, like congestive heart failure, we really want to restrict and have good monitoring and restriction of their input, because the more we increase their intravascular volume, the more work it's going to put on a heart that's not able to handle it. So that's a case where you may not want your intake to be equal to or more than your output. Okay, sorry about that tangent. Here again, everything that is liquid at room temperature is considered oral intake. All right. And then, of course, IV fluids or any medications that we put through that are liquid or that we put through the IV. Blood products, of course, is IV. Any nutrition that we give, like through an NG tube or TPN is an intake. Any irrigations, again, anything that we put into the body, we have to calculate in our intake. And then our output is anything that comes out of the body: urine, emesis, liquid stool, so diarrhea, any wound drainage that we can calculate, any bleeding, any irrigations that we do, so the fluid we put in goes into our intake total, and any drainage of that fluid goes into our outtake total, or our output total. Blood can be measured, and so everything that comes out of the patient's body needs to be measured and put into our output totals. So some of our patients that had fluid volume overload and a poor heart, congestive heart failure patients or things like that, hypertensive patients, we may be doing daily weights on these patients where we're actually weighing them at the same time in the same patient gown, the same time of day, and we're recording their weights, because that's another thing that's just going to tell us about their fluid volume status. And so a change in a kilogram of weight is equal to a liter of fluid. So if they lose a kilogram or they gain a kilogram, it's a liter of fluid. And that's one of the reasons why we do kilogram weights, is because it's just an easier conversion to actual fluid volume as opposed to 2.2 pounds, okay? So 1 kilogram is equal to 1 liter of fluid, and 1 gram is equal to 1 cc of fluid, okay? All right. We're going to assess for edema, of course, and we've talked about this till we're blue in the face. We need to locate document where the edema is, how far it extends, if it's pitting or if it's non-pitting, and then the edema that is too hard to indent, too firm, brawny looking, and even oozy looking. That's brawny edema, okay? Here is your grading system for pitting edema. Now look, so there's no grading for non-pitting edema. It's edema, you push on it, it doesn't indent at all, and it doesn't last, so it doesn't indent, so it couldn't last any amount of time. So some people would call that +1 edema, or you could say non-pitting edema, okay? All right, skin turgor and mucous membranes we're also going to be assessing. So you assess the skin turgor, usually at the hand area, forearm area. You can assess skin turgor, on the forehead or on the chest, but usually it's on the hand or the forearm. And then we're looking at mucous membranes, so the moisture of mucous membranes. And just remember that when you're looking at mucous membranes, the mucous membranes may be moist, okay, so it's not indicating any type of fluid volume deficit, but they have dry, cracked lips. So just be careful. If you just look at the lips, if someone has dry, cracked lips, they could have it for other reasons than being dehydrated, okay? So look at the mucous membranes in their mouth, okay, or in their nose. Tongue and mucous membranes, okay? Yes, be careful about the dry, cracked lips. All right. The other things we can do to assess our patients is, of course, diagnostic tests and lab tests. So, you would be doing maybe a CBC. You would definitely be doing a complete metabolic panel or a basic panel. That's going to check for electrolytes. And then urine will also so we'll tell you about their fluid balance, or if they're dehydrated or not, okay? When we're looking at acid-base balance, we're going to be doing the arterial blood gas. It's going to tell us about our pH, our CO2, and our bicarb, and it's also going to tell us of our oxygen as well, our partial pressure of oxygen. So this is kind of a good form to look at. Easy way to see whether you have a respiratory acidosis or alkalosis, or whether you have a metabolic acidosis or alkalosis. So remember, if we have an acidosis, our pH is going to be down. It's going to be less than 7.35. If we have an acidosis, that will be the same if it's a respiratory acidosis or if it's a metabolic acidosis. So one, we want to find out, do we have an acidosis or an alkalosis? If we have an alkalosis, our pH is going to be high. So first you determine that. Is it acidosis or is it alkalosis? Okay. Then you look at your PCO2. Is our PCO2 elevated? Is it decreased, or is it normal? So if it's normal, then if our PCO2 is normal, then it is not a respiratory problem. If our PCO2 is normal, it's not a respiratory problem. It's a metabolic problem. If our PCO2 is elevated, then that means that we have a lot of CO2 in our bloodstream. The CO2 is an acid. That means we're acidotic. It's PCO2, so it's respiratory acidosis. Our bicarbonate will be normal because there's no metabolic or renal component. Okay? If we had compensation, we would see that our bicarb would be elevated because we are trying to retain or form bicarbonate to neutralize our acidosis. So if we had a compensated respiratory acidosis, compensated means that our pH is normal. So this will be normal. This will be elevated, which will tell us it's a respiratory acidosis. And this will also be elevated because we know we've got the kidneys compensating. Okay? All right, so same thing with respiratory alkalosis. Our pH is going to be elevated, so that's going to tell us alkalosis. Our PCO2 is going to be low, so we know it's a respiratory component. So now it's a respiratory alkalosis. Our bicarb is going to be normal because bicarb is not affected by our respiratory system. And then if we compensate, if our kidneys compensate, they're going to start retaining hydrogen ions. They're going to start excreting or stop forming bicarbonate ions. So we will see this number to be low. We will see this number to be normal. That means we're compensated. Okay. Now in metabolic acidosis, so we've determined it's an acidosis because our pH is low. Our PCO2 is normal, so we know it's not a respiratory component, but our bicarb is low, so we're losing bicarb. So that means it's a metabolic acidosis. Now, if our lungs kick in and try to compensate, if it's compensated, this will be normal. Our pH will be normal. Then we will see that our PCO2 is low because our lungs are trying to blow off acid to compensate for this low bicarbonate. Okay? Metabolic alkalosis, so if it's an alkalosis, our pH is going to be high. Our PCO2 is going to be normal because it's not a respiratory component, and then we will see that our bicarb is high. That gives us our alkalosis. Now, when we compensate, our lungs will kick in, and they will try to compensate by retaining CO2. So we're going to see this normal go up, and we're going to see that our pH is normal. That means we've compensated. Okay? So again, if this is really confusing, let's talk about this face to face. So you just need to let me know. Okay? It is confusing. It is really confusing, but if you just talk through it one step at a time, you will understand it. So first thing you do, what is your pH? Is it normal? Is it high? Is it low? Figure that out. And then look at your PCO2. Is it normal? Is it high? Is it low? Figure that out. Then look at your bicarb. Is it normal? Is it high? Is it low? Okay? All right. So here's your ABGs again. Here is your normal numbers. Please learn these. Okay? Please learn these. All right? Okay, and this is a step-by-step walkthrough of interpreting those blood gas values. Now, the only thing we didn't talk about is your PO2. The normal PO2, remember, is 80 to 100. And so if you're below 80, then you know you're hypoxic in some way, shape, or form. But how hypoxic are you? They've put it in different levels. So if you're 60 to 80, you're mild. If you're 40 to 60, you're moderate. And if you're less than 40, you're severe. You have severe hypoxemia. Remember, PO2 is measuring the blood, or the O2 in the blood. So it's going to be hypoxemia. Low oxygen emia in the blood. Okay. All right, so we've already talked through all this, so I'm just going to move through these slides. I'm sorry I didn't follow the slides, but I even like to see those tables when I'm trying to interpret my blood gases. Okay. All right, so here's your nursing diagnoses for people with fluid and electrolyte and acid-base imbalances. Here's some more thorough written out nursing diagnoses. These are also good ones to use, but may not be as evident or as obvious as the other ones. Okay. Here are your patient outcomes, your patient goals. And then here is our implementation and our evaluation. So again, I'm not going to talk much about IV fluids. I did just put this in there kind of because I didn't know what else to do with it. You've went over this. You've had this in pharmacology. So it's just a little reinforcement for you, okay? Advantages to using IV routes. You guys have learned this as well. This is probably just a little bit of a review for you. Wow, I put a lot about IV fluids. So you guys are learning this. Your 5 rights. Here's your 5 rights, okay, spelled out. All right, you guys know these. All right. I did go ahead and put these in there. You've probably covered this in pharmacology. You can review this. This table on page 1013 lists all the different types of fluids that you can be giving patients. It throws them into their categories of crystalloids or colloids. It shows you again what I showed you earlier about which ones are hypotonic, which ones are isotonic, which ones are hypertonic, okay? Okay, so this is more about IV therapy. It really shouldn't be in this section. This is not going to be on, yeah, we're not supposed to be covering this, but this is a good reminder for you guys, or a good review, so you can go through this. All right, IVs, more IVs, more IVs. I can't believe I left those in there. So, just remember, with patients with fluid volume excess or deficit, yes, like you think about starting an IV, but remember, sometimes it's not the IV fluid that they need. Sometimes it's the replacement of those plasma proteins. Sometimes it can just be oral hydration. And remember, sometimes it could be like they need a fluid restriction, so they don't get IVs, and you're restricting their oral fluid intake as well. Sorry that this had to be recorded. Please, 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 if we have to go over this again face to face, let me know. This is kind of a complicated section. There is a lot of memorizing and learning the different electrolytes, the different values, your ABGs, your all those kind of things. So get yourself some flashcards, work in groups, learn these, okay? Because you're going to need them throughout your throughout your semesters, and then you're going to need it when you get working, okay? I will talk to you guys next week.